Okay, good afternoon and a very warm welcome to this online event on preventative healthcare in a post-pandemic world, strengthening CVD care through population health, co-organised by the British Chamber of Commerce to the EU and Belgium and Novartis. My name is Janneke Davis. I will have the privilege of moderating an entirely interactive discussion after some brief introductory remarks and a short presentation to provide some context for our discussion. A little bit of housekeeping before we get underway. If you have a question or comment to our panel, please use the Q&A box button at the bottom of your screen, not the chat, the Q&A box, and please keep your question as brief as possible so I can see at a glance what you want to know and who your question is for. If you have a technical issue, you can use the chat to communicate with our marvelous team behind the scenes. If you would like to tweet out about what we are hearing, and we do urge you to get the CVD message out, please use either hashtags CVD or Stronger Together. So it's my pleasure first to introduce a video by Tomislav Sokol MEP. He's a passionate advocate for the cause of patient access and, among other things, a member of the MEP Heart Group and the European Parliament's Special Committee on the COVID-19 pandemic. He couldn't be with us, but he did want to talk to you today. So let's hear what he has to say. We seem to have a sound issue at the moment. Can we fix the sound? Something seems to have gone awry. Do we know what the problem is? I'm just waiting to see if there is a message about what has happened to our video, which we appear to have lost for the moment. I tell you what I'm going to do. I'm going to move on and we will come back. I will introduce the video, hopefully again after our opening presentation. So I'm delighted to welcome Beth Evans, the Head of Population Health Management at NHS England. And she's going to, as I say, set the context a little bit for our discussion this afternoon, talking about how new partnerships can improve health system resilience. Bev, great to have you with us. And just to say, Bev will be joining the panel afterwards, so if you have any questions for her, you'll be able to ask them then. Bev, over to you.
Thank you so much, Jackie. So I guess what I want to highlight is population health management is all about partnership working. It's a partnership approach that improves population health by data-driven planning and delivery of proactive care. And proactive care is so important in terms of CVD. We use segmentation, stratification, and then you can actually have the opportunity to identify at-risk cohorts. I think what's really important in this context is 80% of what makes us healthy and happy is not healthcare. So thinking about a much wider approach to tackling CVD and thinking about the recent global pandemic, which we're still going through, and that light, that really shone a light on health inequalities and that we don't all start from the same position. So therefore, how can we think about equity rather than equality? We don't give everybody the same services because we're all different. I think a very profound quote that I heard during the COVID pandemic was, we may be all in the same sea, but we're not in the same boat. I think looking at some of the stats, particularly in England, is that our healthy life expectancy is falling and our years in poor health is increasing. So when we think about life expectancy, we also really want to think about healthy life years, and something like heart failure has a huge impact on that, not in terms of what you can just do, but your mental health as well. Tobacco still remains one of the top risk factors that drives the most deaths, as does a high BMI and high blood pressure. All of these things are preventable and can be managed. a few years ago, we wrote something called the long-term plan, and that set out what we wanted the NHS to do over the next 5 years, over the next 10 years, I'm sorry. And CVD had a very strong focus in that plan. And CVD remains the leading cause of premature mortality in England today. I think it's important to note that one of the risk factors is smoking, and smokers see their GPs a third more than non-smokers. And we have 7.6 million people living with CVD. And I think it's also important to reflect where we are because of the pandemic. So many people, for a myriad of reasons, were very nervous about interacting with health services during COVID. So therefore they stopped necessarily going for checkups. So that has meant that we're likely to see more people being diagnosed with CVD. So that figure could potentially go up. So I guess what's really exciting at the moment is the new white paper, Integration and Innovation, has just received royal assent. And that really talks about the 4 purposes of an integrated care system, of which there are 42 in England. And that is around improving population health and healthcare, tackling unequal outcomes and access, enhancing productivity and value for money, and helping the NHS and its partners support the broader social and economic development. So really taking a value-based healthcare approach and really thinking about how do we then support each other in partnerships in thinking about how to support people with CVD. I think prevention is a new operating model almost that the NHS is going to have to think about. And how we really move to some of the things that we already have in place and make them stronger. So we have a flagship policy at NHS England called 20+5. So it's a health inequalities framework essentially, and the 5 are clinical areas, and one of those 5 is CVD. The 20% is the lower deciles, and that means it measures your access to income essentially. So we all know that if you live in a poorer area, you have less access to money, your health outcomes are worse. So you look through the lens of deprivation. And the plus is about what matters to that population. So it could be ethnicity, or as a recent London system told me, it's actually unemployment in their system. So really wide range. It could be learning disabilities. So there is lots of opportunities within this framework to look at CVD in terms of preventing it, secondary prevention and primary prevention, and then keeping those people well with CVD. I also think it's really exciting that we have the NHS app. This has been downloaded I think 17 million times now, because it also contains the COVID passport. And within that, we do have blood pressure monitoring that can be accessed. And lots of systems, the 42 systems I just mentioned, are developing apps that enable patients to take their blood pressure for it to go directly into the GP record. So you can really start to see how you can prevent some of these things. So I will stop there, Jackie, and hand back to you.
Thank you very much indeed, Bev, and lots to discuss. As you said, this new operating model you were talking about, want to come back on what that care system looks like, how you get to where you need to. Just to say, someone who's raised their hand, we are, in the interest of time and to squeeze as many questions in, taking written questions today. So please do put your question into the chat. Let me introduce I'll tell you what we're going to try and do. Before I introduce our panel, we're going to see if we can show that video by Tomislav Sokol, MEP, again, before we go to the panel. Let's see.
Greetings. My name is Tomislav Sokol and I'm a member of the European Parliament. Firstly, I would like to thank the organizer for setting up this event on this very important topic. With the COVID-19 pandemic, the world has experienced a wake-up call on the pivotal role that health plays in driving economic stability and maintaining a well-functioning society. To increase the resilience of our healthcare systems in the future, it is vital that we tackle the diseases that represent the main health burden for the European population. Despite important medical advances over the last few decades, cardiovascular diseases remain the leading cause of death globally and the #1 cause of death in the EU. According to the statistical data, each year there are more than 6 million new cases and over 1.8 million cardiovascular disease-related deaths in the EU. All these cost the EU economy over 210 billion euros a year. Therefore, we must improve and invest in diagnosis, early detection and stratified therapies, both at the EU and member state level, and encourage initiatives that focus on this. Unequal access to healthcare and inequalities in the management of cardiovascular diseases across the EU have been a long-standing problem, and it has only been aggravated during the COVID-19 pandemic. For example, if you live in Sweden, you have an 8.5% chance of dying after an acute myocardial infarction, a heart attack in more general terms, but in Hungary it's 18.8% chance of dying of a heart attack. There are still significant differences in the performance of health systems and the quality of their outcomes across the EU. Therefore, all the EU instruments should be used to their maximum extent in order to provide meaningful solutions. It is encouraging to see that following the completion of Europe's Beating Cancer Plan, attention is now also on other non-communicable diseases through EU for Health programme and Healthier Together initiative. EU for Health and Horizon Europe, but also cohesion policy, can leverage investments in research and innovations to improve cardiovascular health and tackle health inequalities. To conclude, COVID-19 pandemic represents a historic transformational moment for investments in European health systems. We need to ensure that people can live longer, healthier lives, regardless of where they are born in the EU. I wish you a fruitful debate, and thank you again for having invited me today.
So, Tomislav Sokol there, ladies and gentlemen, underlining the importance of this issue, why we need to tackle CVD, particularly in the wake of the COVID pandemic, why we need to do more in this area. He also underlined the importance of that preventative action, of diagnosis, of detection, that holistic approach. That's what we're going to focus on a lot this afternoon. And the role of EU instruments in all of this. He mentioned the EU for Health programme. He also mentioned the Healthier Together initiative. What does all this mean? How can the EU support member states in introducing the sorts of innovations, the sort of collaborations and partnerships that will be needed to address these issues effectively? A lot to come back to. Let me introduce our panel. Delighted to welcome back Beth Evans, and also Martin Vestweber, Vice President of the European Heart Network. Great to have you with us, Martin. Francesca Colombo, Head of the Health Division at the Organisation for Economic Cooperation and Development, OECD. We have with us Mattea Todd, Senior Investment Engagement Advisor at the UK Government Office for Life Sciences, and Janneke van der Kamp, Head of the Europe region for Novartis. Very warm welcome to you all. This, as I said earlier, will be a totally interactive discussion. I have some questions for our panel, but please do, if you have any questions, please do put them in the Q&A box, and please be as brief as you can. Let's jump straight in. And Martin, let me come to you and from a patient perspective, because this is all about delivering better outcomes for patients. So for you, what do you see as the key challenges, going back to the title of our event, if we are going to strengthen the resilience of our health systems, and why do you see focusing on preventative healthcare? We've already heard that stress. Bev called it the new operating model. Why is this so important?
Thank you very much, Janneke, for this friendly introduction. Hello to you all, to the participants of this very important meeting. In the view of the European Heart Network, I represent here and represent about 30 heart foundations in Europe. I think it's very, very important to have national CVD strategies to improve cardiovascular health overall and create more resilient and equitable health systems. Very, very important. And why this is important to get to prevention. We all want to keep people healthy, but we have to manage their risk earlier, I think. And we all know that prevention is better than cure.
Absolutely, and what that means and how we do it, absolutely central to our discussion this afternoon. Francesca, from your perspective, what are the challenges ahead to build that resilience and to build this new focus or additional focus now on prevention?
Well, quite clearly, lots of things, and I could not agree more. Obviously, the starting point is to build the resilience of populations. So if we have populations with multiple chronic conditions, because obviously also of aging populations and so forth, if we have vulnerable population groups among the most disadvantaged, well, those are the ones that are most likely to suffer. And we have seen even in the data on mortality that those population groups disproportionately suffer the effects of COVID-19 in terms of mortality and foregone or delayed care. There are obviously wider learning from the pandemic in terms of having a health system that is more resilient, more agile, more able to mobilize critical care and resources, which needs to have, of course, a strong, very strong health workforce underpinning to be able to deliver care in an agile way. But I would really emphasize the issues of those inequalities, which have been amplified throughout the pandemic, and the need to think of a systemic approach and not just a pandemic preparedness narrowly defined.
Thank you very much indeed. Lots to come back to. Mattea, very warm welcome. Thank you for joining us today. For you, the challenges ahead, and if I can sort of begin to move us into the focus of our conversation today, because we're talking a lot about population health, we're talking about partnerships. How can we really help to deliver here? What for you are the challenges, and how important do you think? I think there is an example, the UK government entered into last year a groundbreaking, a world first agreement with Novartis, NHS and Novartis, to tackle this issue through a population health management approach. Could you say 2 words about what that was, and then we can maybe consider later in our discussion whether we can learn from that and similar initiatives that are developing across Europe?
Yeah, of course. Thank you for having me. So yeah, I'm from the UK Office of Life Sciences, and we're a joint business health unit, which I think is probably why we're a sort of useful perspective to have here. And I think the focus on for us is really championing research, innovation, the use of technology, transforming healthcare. So when we think about key challenges, I think for us, one of the things that we think is the most important is finding ways for industry, academia, policymakers, NHS to really work collaboratively together. And the partnership, which I can talk more about, is such an interesting example of us taking that really innovative approach. So actually, looking at a problem and finding these groups who maybe were working in silos and actually saying, how do we come together to try and solve this problem? Not as industry separate from government or separate from the NHS, but actually, collaboratively and really get the best patient outcomes possible. So, yeah, definitely a challenge, but also something that I think the UK has an exciting story to tell.
Thank you. Maybe come back on some of the lessons. I know it's quite a new agreement, but lessons so far, and as I say, what that means for others. But Janneke, complete the picture for us, if you would, in terms of the challenges, but also already, if you could touch on that important issue of the partnership, of collaboration, of working together on this.
Yeah, thank you, Jackie. And MEP Sokol already mentioned some challenging statistics, right, on the burden of cardiovascular disease. But the 2 that actually shocked me most when I heard them was the first one, that 80% of the cardiovascular premature deaths can be prevented if we would only use what is already available to us today. So between lifestyle changes and the treatments that are available, if we would only use those, then we could prevent 80% of current cardiovascular deaths. And that, of course, is a big challenge, but I would also see that as a positive. It's also an opportunity that if we find better ways of bringing the patients, especially those patients at high risk, together with the interventions that are already available, we could actually do a lot of good and have a lot of impact. And the second statistic, as a subgroup of this one, is when you actually look at patients at very high risk, so patients that have already had a heart attack or a stroke, for example, you would expect that they are very well managed. But a recent European-wide study has shown that actually only a quarter of them achieve their LDL, their lipid, their cholesterol targets. So now we're talking about patients that you would think should be even better looked after, and even those are also not reaching their targets. So to me, that is a challenge, but it's also an amazing opportunity. It's not easy to fix, otherwise it would have already been fixed. And that's where I think the partnerships come into this equation to fix it together.
And that partnership that I mentioned between yourselves and the UK government is precisely to identify and target those patients in a new way. What for you, Janneke, just to stay with you for a moment and then come back to Mattea and get everyone to react, what for you makes this partnership, this approach so different, so new, and why are those innovations so bad? There's a very nice phrase I read somewhere about bringing science to the patient in a way that is as innovative as the science itself. Why is it so innovative, and why do we need to be so innovative on this issue?
You know, based on the quotes I just gave, we just know that the current model doesn't really work, right? We have lots of innovative medications and other treatments, but there are lots of different reasons why they don't get to the patients that need them. And that's a big frustration that we as a company have, and I think many players in the system have. And that is why, you know, we got together with the NHS and thought, okay, let's turn this around. How can we turn this into an opportunity? And indeed, as you said, it's specifically focused on those very high-risk patients that have already had an event. And what I think is truly unique about this partnership is that, and I see it on a day-to-day basis, it is really one team between the NHS and Novartis, whereas one team, we're trying to figure out how to identify these high-risk patients, how to bring them back to the clinic, how to make sure that the right incentives are in place to treat them, how to make sure we monitor them and don't lose them and measure their outcomes, etc. It's truly a joint objective and a joint accountability to improve care for these patients.
Thank you very much. Mattea, just so that we have that picture and we can use it also to inform our discussion, what for you is the central feature of this partnership, and why is it so groundbreaking?
So I think it's groundbreaking for a couple of reasons. One is the way that it's set up. So, you know, this partnership has 3 strands. So it's not just the commercial agreement, but that's a huge part of it. So driving a population health implementation. It's also the clinical trial aspect, and then a manufacturing development consortium. So it's the first time really that we've thought about these things in the round and brought together all these different partners. And I think the Accelerated Access Collaborative and the NHS, who are sort of delivering and leading the rollout from that perspective, are really trying to find innovative ways to make this collaboration happen. And there's a huge amount of, you know, senior involvement and oversight. You know, ministers are incredibly interested in this. We've got a lot of that commitment from all parts of the system. And so you look at the individual, there are innovative parts within it. So look at things like the patient ID system, you know, that's going to be an incredible tool to get this to the right people at pace. Look at having a centralized budget, and a new service for delivery. So rolling this out in primary care networks rather than at secondary care level. That's a really innovative approach for a deal like this. But all of those things together, is the point.
Exactly, it's that pulling it into, as you said at the beginning, instead of working in silos, you're all trying to address this. But this presumably, and we'll come back to it, requires a big change in thinking, in mindsets, in approaches. Bev, broadening out from the specific agreement to more generally the role of partnerships in all of this, how do you see that, and how do you see involving all the different stakeholders who need to be involved? I'd like to hear from Martin in a minute. I started with him at the beginning because, of course, the patient at the heart of this. But is that one of the keys to really finding effective answers for your new operating model, as you put it?
Yeah, definitely. I don't think any part of the system can do this alone, whether that be commercial relationships with the voluntary sector, relationships with local authorities. They're going to be key in England because that's where our public health colleagues sit. So in terms of true prevention, having them leading some of this agenda is really, really important. And I think that for collaboration, we have to think about infrastructure. So it's really interesting thinking about, you know, how are you going to collate the data that makes you move to a more precise way of targeting populations to give them the right treatment at the right time. And also that intelligence, that's like really super important. So when I talk about intelligence, I'm absolutely in no way suggesting that we start sending out lots and lots of Excel spreadsheets. I have lots of GP friends that beg me not to. So when we talk about actionable insights, it's looking at, a graph that makes you want to take action. So intersegmental drift, for example, this is meant to be a progressive disease. If you show a GP that their population is jumping from 1 to 3 or 1 to 4 or 2 to 4, they really want to understand why, because it's a progressive disease. You should slowly go through that. So they want to find out more. And then the interventions. So it might be an introduction to a walking group. It can really be that simple, smoking cessation, weight management, all the way through to the drugs that if you need those. So how do you target those people, especially those at-risk people? And then the big one, I guess, the kind of exciting one is incentives. So how do you incentivize people to work together to do the right things? And this is really tough because, you know, I've talked to people all over the world, from Saudi Arabia to Canada to Australia. We all have this focus on hospitals, and we're driving this through primary care, interestingly. Yeah. So it is about partnerships, but also I talk about populations and people, and that's because I think people at risk of CVD are people. They're like me. So they're unseen in our population. And I think that we need to change our relationship with them to make it work. And I think digital is another great opportunity where we put people more in charge. And I can come back to that and give some great examples.
But as you say, also the digital has infrastructure implications, all of these things. How do you get the data? How do you store it? How do you do it? I just want to come back on 2 points there. Francesca, Bev was talking there about incentives and how do we get that right? Just a word, if you would, on the importance of these new types of partnership, on using population health management approaches to all of this, and how you see the role of incentives within that, how this works from a financial perspective.
Look, I think it's a big question. First of all, yes, innovative approaches, but let's keep in mind the population health aspects, that there can be maybe a particular innovative approaches for a particular type of treatment, for example, but that broader perspective that has been mentioned about how do we tackle the population health more broadly, you know, so looking really at all individuals and addressing things like lifestyle, like the way we eat, the way we move, those you know, risk factors, which are the ones that determine then the differences in cardiovascular disease and in outcomes from cardiovascular disease. So I think it's quite fundamental to situate any also innovative approaches within that broader health system that take care of the primary, secondary cardiovascular disease prevention in a very, very holistic way. And incentives, I mean, obviously it's always incentives, but it's really the way also how you nudge people behavior, how do you make for them the healthier choices in terms of the way you move, you eat, for example, the easier choice. You know, those are things which are very, very important because, you know, because of differences also in socioeconomic groups and how, you know, the type of information that people have, the very low health literacy that we have, you know, it starts really very much upstream in the disease pathway program. And we always say, and we always remember that the spending on prevention is less than 3% of total health expenditure. But the fundamental really start from those, you know, interventions which are very upstreams into the health system. And how you get there, it's almost like a whole of health system, but in many cases, a whole of government's approach. If you think also how you address the way people eat, the way people move, the way people more generally keep healthy lifestyle. So those for me are quite important aspects to point to.
Thank you very much, Francesca. But I'm also thinking, Martin, and from the patient perspective, I mean, yes, we focus a lot and we talk a lot about the lifestyle issues and health campaigns and getting people to change their behavior, their habits and so on. But of course, for many people, they have risk factors that are not lifestyle related, or they can be groups who maybe those sorts of messages don't reach very well. They either don't want to hear them or they don't hear them at all. Do you think maybe till now we've tended to focus a little bit too much on the lifestyle factors and not enough on those who are at risk for all sorts of different reasons?
Yes, maybe. I think it's a question of trust. The people who are heart patients or who don't know if they are heart patients have to trust their general practitioners or their doctors in getting better lifestyle. But another point is, I think we need more screening programs to get the people who have risk factors and they don't know about this earlier in their age. That's a very important point, I think.
Oh, Janneke, you wanted to go.
Yeah, thank you, Jackie. No, I was just combining, Francesca mentioned, I think, in a very important number, only 3% of healthcare money, right, in OECD countries is spent on prevention. And then Martin said, we need more health checks because you don't feel your high cholesterol or your high blood pressure, right? So often patients only turn up in the healthcare system and it's already too late. And I think if you combine these two things, right, that makes it to me very clear why incentives, because that was what your question was about, are so important, not just for patients, but of course also if you look at the healthcare system and there is no per se incentive, doesn't have to be monetary per se, right? But a motivator, a KPI on bringing patients at risk back into your system. If you're not asked or measured on doing that and on preventing events, then why would you, right? The doctors are busy enough, even more busy, I think, these days than before. So I think you touched on a very important point, right? Incentives, what is measured in the system? What are people rewarded on? How is that aligned between hospitals and primary care? And indeed, is it actually motivating people to bring in patients at risk, or is it actually demotivating them because it just causes more work and they don't get any kudos for it?
Sorry, I have some building work, so I have to keep muting myself. As I understand, Mattea, that really is motivating the GP, the primary carers. This is an agreement that gets delivered through them to help identify the patients who could benefit from the treatment. But for them, it can't be too great a workload, and they need to see that it works. How important is all of that? Do financial incentives also play a role or not? Or is it more about making it usable, accessible, and that they can see the results? How does that work?
Yeah, I mean, I think that's a really good point, and I think Bev will probably have more to say, not specifically on this deal, but I think we know that GPs are the ones who really understand their local patient populations, and actually when the decision was made to do this partnership at primary care level, it really was because that's where it could have the most value, and we could see actually the greatest output. I think when we think about how we get GPs, particularly in the NHS, to prescribe something new, bringing the professional bodies with us is a huge part, and I think that's a lesson that we've already learned in this partnership. Actually, how do we do a hearts and minds piece? And we talk a lot about communication and getting patients into the system, and actually a lot of it as well is about really making sure that GPs understand and are invested in and are on board with the mission, because they're such a key part of it. And then we talk about financial incentives, and that is something that comes into this partnership too. The way that we fund the NHS and the way we fund GPs to prescribe is very much done through essential services, and if we're adding additional things, or if prevention becomes a big part of that, it has to be part of the conversation. So it's definitely been something that is part of how we're moving forward with this partnership, and it needs to keep being part of the conversation.
Bev, did you want to add something there? And then I'd like to come to Francesca on this.
Yeah, I totally agree with what everyone has said, and I think it's almost challenging ourselves through the lens of deprivation and health inequalities. So when I think that we already have health checks in the UK, now that a lot of them were paused unfortunately through COVID, but they present a great opportunity. It's just an age that you get called in to have a health wellness check. The issue is, what we've realised is people from lower socioeconomic areas aren't so willing to come forward. So do we need to think about a different system where you're actually incentivising people to really concentrate on those groups that maybe not come forward for that, because they have difficult jobs, they have a chaotic lifestyle, they're worried about putting on their heating. These are the real things that people are worried about. They're scared of filling up their car, they're missing meals. So you have to put yourself in their shoes almost, and think like CVD or diabetes, or they're so much lower down on their priority list than they should be because of what they're actually having to live and cope with. And I think this is where like something like Every Contact Counts really, really can make such a difference. So closing those gaps in care. So if you go to fill, you know, a prescription, can someone take your blood pressure? Can someone refer you on to a healthy lifestyle coach? We have social prescribers in the UK that have more time to spend with people and get under what I would call the layers of the onion. It's not that you don't care that you're at risk of CVD. It's just that, you know, you've got to care for your mum, your child's missing school, and you're worried about your electric bill. And if we all reframe our thinking, then I think we will start to change the operating model.
Thank you. Francesca, could I ask you, just listening to this conversation about this specific agreement and the approach being taken in the UK, to what extent do you think, and Janneke, I know other countries have done it, I'd like to hear a little bit more about what's happening elsewhere, but first, Francesca, to what extent do you think these sorts of partnerships are replicable? I can never say this word, replicable, and if they are, can they be simply copy pasted, or is this something that's going to look different in every country where you try this approach? Is it something that we really do have to tailor, or are there some basic principles to underline such partnerships you think that are important, particularly in light of your remark at the beginning about that resilience in populations?
Look, in any partnership, obviously there are a lot of elements which are very much depending on context and on specifics. I think it has been highlighted the importance of the data, for example. We need to be able to measure in a very granular way and in real life what's the outcome and the results from any new approach. We need to look at existing also treatments. There are huge disparities in utilization, for example, things like statins, to remain on cardiovascular diseases. So, you know, and those might be different between one country and the other. So definitely there are elements which is just depending on context, but I think there are some fundamentals like the way you continue to collect data to have a much more granular understanding of what is happening to populations who are the ones who are affected, but also how the rollout of certain treatments might or not have an effect, particularly if it is a new innovative treatments on which we don't have real life evidences yet. So we do have you know, data that needs still to be proved in real life, and we do have a number of other existing treatments that are actually quite effective or cost effective. So I think all of those depends on particular individual circumstances. It depends also on how the structure of the health workforce is set up, you know, and but I do think that the fundamentals, particularly the data aspects which I mentioned, is particularly important.
Thank you. And MEP Sokov talked earlier about the EU for Health programme. He also talked about the Healthier Together initiative. We'll come back on that, but also listening to you, thinking the European Health Data Space Initiative could play a central role here. But Janneke, as I understand it, the UK has led the way in developing this type of agreement, but there are other countries that either have or are on the verge of doing something similar. Where is it happening? How widespread is it? And my question about to the extent to which it can be copy pasted or is very particular to the particular, how do we get that scale up?
Yeah, no, great question. And a related question that I often get is, okay, the NHS is very centralized, but my country, whatever, is organized in regions like Spain or Italy, or my country has health insurance companies. So how can I, you know, get to a similar partnership, or can it even work, right? So the good news there is that we indeed, to your point, already have partnerships underway in different countries with very different systems and very different contexts. So I'll mention maybe in the US, we're working together with the Veteran Association, which is a very strong association in the US. But two European examples, one more centralized and one more decentralized. So in Hungary, there's also different wealth country. You know, we are working together with the Minister of Innovation and the largest university, Budapest, in a similar population health program, also with a research component, not so much fundamental research, but more, you know, which interventions in Hungary actually give the best outcome when it comes to cardiovascular health. That's Hungary, but then a very decentralized system like Switzerland, where we have a collaboration with one of the major health insurance companies. And of course, many countries, Germany, etc., have health insurance companies, and that can also work. So in Switzerland, we have an agreement signed with one of the major health insurance companies who, back to your point on data, they started doing a calculation of what if we would actually manage our cholesterol better in the high-risk patients. They discovered it would give them not just a health benefit for those patients, but also a financial benefit for the health insurance company. And based on that insight, they were willing to work with us. And now we have a very elaborate collaboration that includes many things you've already mentioned before around patient education, around patient identification, around guidelines, around patient pathways, and around measurement. So yes, it is possible to have these types of partnerships in different shapes and forms, because indeed one country is not the other. Some countries are centralized, some countries are regionalized, some countries are health insurance companies, but you can have similar partnerships, I think, if both parties are willing.
Martin, and I want to come back to Bev and to Mattea in terms of if you have any advice or a lesson that you've learned so far from trying to apply this approach. But Martin, from your point of view, how important do you think these sorts of collaborations are, and the role of the patient in this? How important is it that any partnership like this is inclusive and puts you within that discussion, at the center of that discussion, because it is for the patient? It's also crucial, presumably, that it involves the patient in making it work.
Mm-hmm. I think it's very important to include the patients and the patient's voice. The public, and most notably patients' involvement in innovative public-private partnerships, is a key factor, I think. This, as I mentioned before, ensures trust, and trust is a very, very important point. They can define needs and expected outcomes, which is a key to ensure relevance, value, and efficiency of health systems. And we made the experience in Germany when we developed together with about 40 different stakeholders a national CVD plan, which can make this paradigm shift into reality. But the politicians didn't act now. We try to get them to act now, but it's really, really difficult. We had 40 different stakeholders, including professional societies. We had researchers, patients, politicians, payers, and so on. But now it's time for the politicians to act.
Why do you think it's so difficult, Martin?
Maybe in Germany, but I think in Europe it's nearly the same. Now we have a decade against cancer, as you know, launched by the EU and launched by the German government. But as we all know, it is very important to fight against cancer. But CVDs are the most cardiovascular disease, the disease with the biggest mortality overall, and
as Janneke said at the beginning, 80% preventable, and repeat incidents. So the secondary prevention. So many are repeated. It does seem to me, to be honest, surprising that politicians don't get it.
Maybe they don't get it, but they know it. They know it.
Thank you very much. Just in terms of lessons learned, talking about this scale up and copying this or mirroring this across Europe, and indeed Janneke mentioned also the US. Bev, Mattea, is there one piece of advice based on your experience so far of having put together these sorts of partnerships and how they're working so far? Any key advice on what lesson can we learn about how to do this well? Perhaps Mattea first.
Sure. So I think, one is a hard challenge, and I might cheat by using one that applies to a couple of things. But I think communication has been incredibly important. So, you're bringing together organizations who work quite differently and have different approaches, and actually finding ways of aligning those and bringing together the different partners has been incredibly important. And we've really seen improvements when we've found effective ways to do that. I think also then communications to the wider parts of the system and having them at the table from as early as possible. We talked about the importance of the clinicians on the ground, and actually they are vital for the rollout and occasionally too easily forgotten if you're you know, sat in a room in Whitehall and not kind of focused. And I think the key thing there is how we align this with wider priorities. So, you know, Bev talked about the NHS 10-year plan. We've got the life sciences vision. There's a huge drive here, and actually finding ways to show how partnerships like this one get us to those places is exactly how you bring the politicians with you. And so, you know, doing those two things together has been really important, and something that we've seen have a big impact on the kind of rollout of this partnership. But Bev might want to talk more.
Thank you. Bev, is there one sort of key message you would identify to get this going?
So I'm going to bring it back more down to like a level of how we engage. It's really interesting. We talk about all these strategies, don't we? But we haven't got much evidence that they've worked. So if I think about the obesity strategies in England for the last 30 years. So I guess for me, it is coming to an equal partnership with people that live in your population and giving them back some of the power. And that's what I talked about digital earlier. So in Dorset in the United Kingdom, they're using 3 apps at the moment, 3 different types of apps for CVD. So they go from, you know, My Heart, which is a structured cardiac rehab, and it enables patients to understand their own deterioration, but also that they need to reset and do something different, or they can escalate to their consultant or their GP, all the way through to, you know, blood pressure monitoring app that goes straight into the GP record. So there's that link. But also one of the most exciting ones when we talk about prevention, which I think that we all want the golden panacea, is the Healthy IA app, which is Kidney Minute, and it uses the same test to test for kidney failure that it does for CVD, like at-risk patients of CVD. So there's huge benefits in digital, but using digital for the population to become our equal partners in this, in helping support themselves, I think.
Francesca, could I just come back on the point that Martin was making about political will? Because clearly, if you want this sort of system level change, you need political commitment, you need political will, as well as, you know, whatever needs to be done in budgetary terms and so on. Why do you think, given how important this issue is, and you've all underlined it, and you were talking about that importance of building resilience, and we've learned from COVID how important that is. Why is it, do you think, such a difficult sell to really get this focus on partnerships for prevention and collaborating and focusing on both primary and secondary prevention?
But the political issues is not just on the partnership. I mean, it's more broadly. How do we, for example, invest more in health? And lots of discussion going on right now following COVID-19. That probably we need to invest more to have more resilient health system and supports. But we also know that 15% of government budgets, and I'm talking about across OECD, are absorbed already by health. And so it becomes an issue of where do we put the government's money? Do we put it more into health? It means less somewhere else. Are we willing as a society to chip in more resources? Are we willing to raise more funds through tax mechanisms and so forth? And it becomes, you know, a societal discussions as well on opportunity cost and where we are. And I think those discussions need to be taken a little bit in the broader. It's not a matter of the partnership here and there, because then become too micro on issue. And unless we situate any kind of partnership as well, any kind of interventions within a more integrated system approach, then we're going to go, you know, really and fail big time. It's not that one little thing will make the difference. Now, health systems have been historically incredibly rigid. They've been set up to be about diseases, not about prevention, continuity, and so forth. They were set up decades back when the epidemiology of the populations was different, and they were set up in rigid way, partly to guarantee quality of care and, you know, decide so what would doctors do that nurses could not do, and what would be the roles of hospitals and so forth. So we have created, because of wanting to ensure since certain standards, a very rigid system that is somehow struggling with a change epidemiology, which clearly the needs to become much more preventative, much more anticipatory. with a digital transformations that has struggled really to permeate into health systems. We've seen much more things happening through COVID because there's been a shock, but otherwise health was lagging behind all the other sectors of the economy. And so in a way, I think again, yes, you know, a public-private partnership, but we need to have that more system-wide and situate. How do we integrate a particular experiment, a particular approach within that broader architecture? And unless we really change and address fundamentally that broader picture, then it would be very difficult to have systemic change.
Because in a very general sense, just to follow up with you, Francesca, the proportion of health system budgets that are spent on prevention is tiny, and yet
the proportion of total health spending,
yeah,
so budgets or private spending, it's 2.7%.
Exactly, and yet the cost savings that can come from prevention. I mean, is it simply that the pressures on the system are so great at the moment that looking at anything that isn't the immediate need to treat those patients who are already ill is difficult to get?
It's not. It's partly can be the pressure. You know, it's the people are used to do the way as they are. Your parts, the way also. Perhaps physicians are trained, you know, to look at how attractive is being a public health physicians. It's not attractive. It's the specialties. That's where you get the prestige, if not the money. So, you know, that's what I'm saying, is that it's the system is set up in a way which is not about anticipation, prevention, about continuity of care, about putting patients at the center and all these things. It's that fundamental change. I'm not saying that it's easy, and it's probably something that if you talk to policy and decision maker, they would completely recognize that that's the way to go. It's making the change, which is obviously difficult because of.
So we know we know where we need to go. It's how do we do it that presents the challenge. Mattea, I think you wanted to jump in there. No, did you signal? No, I thought you had. I'm going to take a couple of questions from the audience, and then I'd like to come back to what our member of the European Parliament, MEP Sokol, was talking about at the beginning about the role of the EU within all of this. But we have a few questions from the audience. One quite specific from Peg Maguire relates to women, saying CVD impacts women at a later stage in life around menopause. Should they be targeted specifically? Which actually, I mean, I would ask, how do you identify? So when you say, okay, we need to target the at-risk groups and so on, in an agreement like this, in a process like this, how do you decide who you really need to target? There's another question that's very specific, I think, to the UK, so I shall leave that one. Just in terms of identifying which groups and the women question, who can help me with that one? Wave at me. Bev.
So, from a population health management approach, it's exactly what we do. It's data-driven decision making. And in England, we've been really fortunate that our systems have linked all their data. So if I take an example in Bristol, they wanted to look at patients at risk of heart failure, but they were aware that every contact counts and they could be much broader than that. So really thinking about the risk factors and bringing those into it as well. And we know deprivation is one of those risk factors. So really looking at that. And in answer to the particular question, should we be targeting women? Yes, that's personalized care. That is understanding what your target cohorts are and then reaching out them to understand where they are. So your interventions actually can fit where they are in their lives. And, you know, there's been a lot of news in the UK, I don't know if it's reached Europe or not, about the menopause at the moment and what women go through. So I think if that's an added risk, then it should be considered such. And I think it's really interesting looking at a lot of the UK waiting lists at the moment for elective care that demonstrate that women actually wait on waiting lists longer. And that's because they're usually the primary caregiver. So they're the ones delaying some of the treatment they can get. So that's in a wider context of women's health inequalities, I think.
Thank you. And Janneke, just to this point more broadly about identifying those at-risk people, and when you have an agreement like you do, I think you're aiming to help some 300,000 patients, but identifying precisely who should get that treatment and who really qualifiers, because you're going to have to prioritize, and we go back to the budget issue, all of this costs, which is one of the reasons sometimes prevention falls down the wayside. How do you go about it, and how important for you is it that you involve patients in those conversations, so that the system is seen, going back to the point about equity and equitableness, that the patient is involved in those conversations?
Sure, and I'm sure Mattea can talk about this as well for the England situation specifically, but indeed it's a very pivotal part of this collaboration, is identifying those patients at high risk. And there is a specific algorithm that was developed and that is now being implemented in the IT systems in England, so that every primary care physician, because as Bev said, it's a primary care-led intervention, every primary care physician can basically print out their list of these are the 20 patients that I need to call in, or gets a pop-up of, okay, when this patient comes in, this is one where I need to actually double check their cholesterol and make sure they're treated to guidelines. So that algorithm and how it's implemented in the IT systems is absolutely a very important part of the collaboration. And to your point, and again, I think Mattea and Bev are very well positioned to talk about this, but specifically targeting the populations that are at higher risk and are not engaging with healthcare maybe as much as others is also a very important part of this collaboration, and also of some others. I mentioned a few, but for example, in Dublin, in the city Dublin, we have a very specific collaboration that again specifically targets patients in a group that normally doesn't engage so much with healthcare in a less privileged part of the city. So clearly that is an important risk factor that we also try to address in some of these partnerships.
Martin, you wanted to come in, and I'm thinking also here, I think we've tended to think of CVD as more of historically as more of a male problem, and women perhaps not thinking they were at risk in the same way. Certainly my generation, we tended to think, if you hear that a woman has died of a heart attack, it seems somehow more shocking. I don't know why, it's generational. But does that mean, Martin, you think that women who are at risk maybe aren't taking it as seriously as men might?
Yes, yes, of course. We saw this in the awareness campaigns in Germany when we have our heart weeks about heart attack or coronary heart disease or other CVDs. Women always come later to the doctor, call the 112 for Germany. I think it's a point of awareness campaign. We have to make more awareness campaigns targeting on this group of patients, on this higher risk patients, in this case women. In this point, I would like to mention a program which we started in Germany some years ago called Cardiolotse. It's run by the health insurances and funded by a national federal joint committee, which belongs to the German public legal entity. The point is, for example, looking at secondary prevention, we supported and partnered with other stakeholders and piloted a regional project called Cardiolotse, whereby the patients after hospitalization follow prevention pathways assisted by a CVD nurse at all times. And the outcomes of this project are expected for this summer, but there are preliminary results look very, very promising. And this might be a good way to find these risk patients.
Thank you very much indeed. A quick word, Mattea, if you would like, on this, and then I'd like to come to the implication of all of this for EU policy.
Yeah, and we've talked about this just now, but the patient identification system being set up is a really important part of this collaboration, and utilising the NHS digital services, utilising the huge amount of data that the NHS holds about these patients. And I think one of the things we're excited about is, okay, this is having a massive benefit for this partnership, but actually it's a big learning that we can take forward in the NHS. If we have tools that can help GPs identify the right patients quickly, that's not only going to be a benefit for this partnership. So I think that's one of the things, is how actually the kind of innovation and the sort of fast approach is actually then benefiting us in other ways. And yeah, so it's an algorithm that we're rolling out through NHS Digital, but it's an exciting opportunity more widely than just this partnership.
Thank you very much. So at the start of our session today, MEP Sokol talked about the EU for Health programme with that money, specifically for innovative health promotion and prevention campaigns. He also talked about the Healthier Together initiative, which is looking at putting together a roadmap for non-communicable diseases. I just wanted, and we mentioned in passing earlier, the health data space. In terms of what the EU can and cannot do in order to support countries that are looking at this and saying, this is an interesting model, we'd like to go down that road. Francesca, in broad terms, how do you see the role of the EU, given the limits on its competences in the health arena, but in really driving this agenda of building resilience as we move forward?
Well, I think the Commission has been doing quite a lot in response to COVID-19 and realizing that while health remains a national competencies, there is a lot that can be done by bringing countries together. Obviously on preventions and public health, there was already quite a lot on the plate, but think about precisely the creation of this health data space, the importance that is given to better being able to leverage data both for research, surveillance, clinical optimizations, but also for making system much more people-centered. Obviously, all that is being done in terms of pandemic preparedness and response. There is some activity that we're directly involved with, which is also looking at understanding the performance of health system in what we call country profiles, and looking really at lesson learned by looking at what your neighbor is doing. And I think that's, in terms of also benchmarking and really looking across the border, I think it's an important role that can be further stimulated. The attention which is now being put on cancer, but also on non-communicable diseases more broadly, I think it's very welcome, of course, again, because the epidemiology of this disease is changing. And in terms of innovative new approaches, which can be done in the preventative space, but also in the cure space, there is quite a lot to learn about useful practices across country. Perhaps having a more standardized approach to measure and assess those practices as well. I think there are a lot of tremendous opportunities from that. So I'm quite positive. There's been really a lot of interest of investments as well, which is going in health and health system more and more broadly. And I think we have the good premises for really making improvements for populations' health and for patients as well across the different European countries.
Thank you very much. Martin and Janneke, and I don't know whether our British colleagues will want to at all comment on this. I'll give you a chance afterwards if you do. But Martin, Janneke, how do you see the role of the EU, and specifically, what do you hope to see in the Healthier Together initiative when we get that detailed document in the summer, in terms of the way the EU spends the budget it has? What do you want from the EU in this area? Martin first.
Thank you. We want to see alliances, more alliances, included the patient's voice. That's very important, I think. We want to see EU-wide campaigns, awareness campaigns, where all the stakeholders work together on this point, on this topic. I think this is very important. We have to screen those people, those patients where we don't know if they are hard patients, and we have to look for very broad awareness campaigns. I think this is most important of all.
Janneke?
So my wish list, two things. Firstly, within the Healthier Together, if we can specifically mention cardiovascular disease, that will be number one on my wish list, because we all know, Beat Cancer, the cancer plan, it resonates, right? And then even if Europe itself may not have a mandate to implement things, countries feel that they are backed up by the European narrative and the European, direction. So CVD specifically mentioned. And then secondly, within that, ideally for me, if Europe can also stimulate secondary prevention. So we talked about, and Martin talked about screening, primary prevention. Yes, of course, important. But as we started with in the beginning, there's so many patients who we already know are at risk and are still not achieving their guideline prescribed goals for cholesterol or blood pressure. If we could focus specifically on those patients, we have a much faster and bigger bang for our buck in a sense, right? We have really the high risk patients. So if Europe could also specifically stimulate that we manage those patients already at cardiovascular risk much more proactively, those two things would be fantastic.
So we have the political signal, you say,
Yes.
is very, very important.
Exactly.
It gives that impetus. And then also I'm thinking, Bev and Mattea, to broaden this out from the EU to Europe and the sharing of best practice in this area and learning from what has been done. We talked about lessons learned from the specific example we've heard about today, but learning from each other, finding ways through, even given the particularities of systems. Do you think more can be done in a more general way to get that sharing of best practice? How can we do it better, Bev?
It's a really good question. And I think one thing that always triggered a great response was something that we used to have from Public Health England, which was a report called The State of the Nation. And that used to benchmark us both globally, but particularly with our neighbours in Europe. And, you know, cardiovascular disease was in the long-term plan because our outcomes weren't great. And that was 6 years ago, fast forward during COVID. So I think having that benchmarking is really important for us to understand. But then understanding the underlying factors of why you're better across Europe than England in some of this. And it's really easy to say, you know, you have better weather, you have nicer food, but there are some really critical things that I think we can learn from Europe in terms of how we manage. And I think some of that is access to diagnostics as well, which isn't actually, it's outside of hospital care. You do your diagnostics quite differently.
Mattea, did you want to add something?
I think just to echo what's already been said, you know, we talked about it before, but when there are innovations or, you know, partnerships like this one, actually taking the findings that can be applicable and learnings and making sure that we're all taking those forward. So yes, there are things that are very specific to the location and the health system, but actually what are the things we can learn for when we're replicating these? I think that's but just to echo.
Thank you. So sharing that practice and showing it can be done. It will be different in different scenarios, different settings, but we can do this sort of innovative approach. There was a couple of questions, and I don't want to take the specifics of them because it's not really for this panel, but they were really about how you decide how you spend money. So Chloe Sheriff was saying, what if we could detect the very first sign of CVD in the ascending aorta using MRI imaging? Could this innovative method interest the UK prevention system? She's asking specifically UK. There was a question which has now disappeared, but about e-cigarettes and should we be encouraging it and so on. I mean, I want to just broaden that out with a quick thought and then we'll wrap up. But and that was specific to Bev, to the UK. So maybe a word on that. But also, all the time, we're going to face these competing new technologies, new treatments, new methods. It is very difficult. And this goes back to health technology assessments and so on. But how do we find a way through these debates? And again, for you, how important is it that Martin and patients are involved in those discussions about what you do, the treatments you do make agreements on, decide to use, reimburse, and the ones you don't? Bev, because it's a broad issue, I thought perhaps you could comment on that.
Yeah, so I think, sorry if I answered the question on e-cigarettes because it's one of my passions. And it's really difficult because we all know e-cigarettes are better for you than smoking. I think my concern, I'd really like to get Martin's opinion on this, is my daughter is 12. She's going to school with people that vape. They've never smoked, but now they're vaping. What's the risk of that? What's the impact of that on CVD? So do we need to really refocus our messaging? We talked about communication and public health. Is there a whole kind of swathe of youngsters coming through that we need to worry about? So my preference is stop smoking, and e-cigarettes can help you stop smoking. We know there's the evidence base for that.
Yeah.
And I think in terms of broadly where you spend your money, that's a real toughie. And I think it's something that the systems in England are really going to have to think about, because obviously an MRI scan is a lot more expensive. And I still think smoking cessation is one of the cheapest interventions we have.
Absolutely, absolutely. Don't have time to talk about that more now, but because I wanted, before we close, just to put you all on the spot a little bit. And this is a very unfair question, but I think we were talking earlier about political will and politicians, and they will often say, well, what do you want me to do? What's the one thing you want me to do? So I'm not going to ask you, I know you've all talked about how important it is that this is a holistic approach, that it's an integrated approach, but going back to what you said at the moment, at the beginning, Bev said prevention is a new operating model. If we are to move to that new operating model, if we are to use the sorts of partnerships, collaborations we've been discussing, innovative ways of doing this most effectively, what for you is the key next step? I told you it was an unfair question, to ensure that we really do strengthen CVD care through that population health management approach you've all been underlining is so important. Francesca, let me start with you. Of all the things we've discussed, what would you focus on as the most important next step?
Well, it's clearly the disparities aspects, and disparities to do in terms of the prevention broadly, but the utilizations of old treatments, which are very effective and cost effective, as well as disparities in access to new treatments. But we need to consider the whole issues of disparities and more granular data.
Yeah, without that data, we cannot make progress. Mattea, for you, key priority, key next step?
I think building systems that can embrace innovation, whether that be, the healthcare system or government, actually that are set up and designed to take on innovations when they arise.
And would you have a key next step to identify to do that? Is it a mindset step? Is it a very practical step? I mean, through the implementation of your agreement, you're doing very practical things.
Yeah, I think part of it's really practical, it's infrastructure and its capacity, and then part of it is a mindset thing, but both of them together are important. Sorry, I cheated, that's not one.
Not at all. I just wanted to press you a little bit because I'm mean like that. Bev, your key next step or priority?
I think we're already doing this, but really using the data to understand the wider determinants. 80% of what makes you healthy and happy is not healthcare. So we need to work in partnership to make sure we can support people with all those other things that stop them concentrating on being healthy and happy.
Thank you very much. Martin.
Yes, thank you. I think the evidence is clear. My first wish is building alliances, very important. Second wish is strengthen the patient's voice and strengthen the people's voice.
Thank you very much. Clear, succinct, and to the point. Janneke, not only, if you would, your key next step or your priority, but also perhaps some reflections on the way forward as we bring this discussion to a close.
Okay, great. So I think, so first of all, I thought it was an intriguing conversation. So thank you very much for facilitating so well and for all the speakers. What I sense is, and Francesca said it very well, health systems are complex. They're set up a certain way. To move them to a more proactive, prevention-oriented way is not easy. So I thought that was good context to have. Having said that, I think what I'm positive about is that the realization that we need to do this, and specifically with the biggest killer in Europe and in the world, cardiovascular disease, starts to resonate everywhere. I hear more and more, okay, I get it, yes, cancer is of course important, remains important, but we need to focus on cardiovascular disease with a different type of approach. What now needs to happen, and you mentioned this before, is to go from this emerging political will to action. And what I would do, I'm a very pragmatic person, is to keep the holistic picture in mind, but actually focus on a case study, because you cannot change the world. You have to slice the elephant in small pieces, right? And the small piece that I would choose is, as probably not a surprise based on what I said before, but is this very high risk population. Those patients that are already have already had a cardiovascular event, are at very high risk. This is where the health system can have the most impact. And it's a manageable population. This is also why in the UK, we focused with the NHS on this particular population. It's manageable. It's not millions. It's a few 100,000 maybe to focus on. So what I would do in that bigger context, I'm happy with the with the motivation that is coming at the European level. As I mentioned before, my wish is, get it into healthy together narrative, cardiovascular and secondary prevention specifically. And then at a country level, pick your case study, most likely where you have most impact fastest, your high risk population. And then of course, cheeky comment, right? But from a Novartis perspective, don't hesitate to reach out. We're highly committed to working with healthcare systems in their different shapes and forms to really, improve patient outcomes in this population. So we're very interested to explore what other partnerships we could be working.
So look where those collaborations can be formed at the local level, with the EU hopefully providing some of that political impetus that Martin suggested was sometimes lacking in some of our politicians. Thank you all so much for a great discussion. Thank you to all of you for your questions and comments. I also really want to thank on behalf of everybody from the British Chamber and Novartis for hosting and organising this event, and the local chapters of the British Chambers of Commerce for helping with the organisation. But most of all, thank you to you for joining our discussion, and it only remains for me to wish you a very pleasant rest of the afternoon. Do take care. Thank you, panel. You were wonderful. Bye-bye.
Thank you. Bye-bye.